And so now we're going to talk a little bit about older adults and intimacy. Intimacy refers to a close feeling shared between two people based on knowledge of and familiarity with the other person. It includes emotional, social, and physical intimacy. Our desire for intimacy does not decrease with age, and there is no age at which intimacy, including physical intimacy in our relationships, is inappropriate. Physical, emotional, and psychological changes that may occur as we age can interfere with developing and maintaining intimacy, ultimately changing the way intimacy is expressed. It's important to note that sexual intercourse is not the only way that we express intimacy. Behaviors such as touching, hugging, and kissing, trust, respect, and compatibility become equally and at times more important as we age. We have a great panel of speakers today with expertise in the areas of older adults and intimacy. We thank you for joining Seniors Blue Book and the Caregiver Support Program as we explore some of the physical and psychological aspects that affect intimacy as we age and learn ways to increase intimacy in our relationships, especially when sex is no longer an option. I'd like to share a little about each of our panelists with you. Pam Mickens will be the moderator for today's program. Pam has been a long-term care staff ombudsman in Dallas County for over 7 years. The long-term care staff ombudsman program for Dallas County is housed at the Senior Source. Pam advocates for frail, elderly, disabled, and residents with mental health illnesses in Dallas County nursing home settings. She attended the University of North Texas at Denton, where she earned her master's degree in criminal justice and rehabilitation counseling. Her background also includes many years in the public and private sectors as a manager of social service programs. She is a strong advocate for quality services for persons with mental health challenges. Pam is also a proud great auntie of Caleb and Bryson, thanks to her niece, Ebony. Congratulations. Our next panelist is EMILIJA Rosenthal. EMILIJA will share her expertise on the physical aspects that affect intimacy. EMILIJA is a certified family nurse practitioner. She specializes in HIV medicine. She received her Bachelor of Science degree in nursing from the University of Texas at Arlington in 2010. EMILIJA then worked as a registered nurse for 8 years prior to going back and attaining her Master's of Science degree from Texas Women's University. She is about to celebrate her 3-year anniversary working at Prism Health of North Texas. And then finally, our last speaker is Dr., I'm not going to pronounce it correctly, Dr. TANGINIKA-SIMONE CUASCUD VEGA, Dr. Tangi. And I'll have her actually say her name correctly for you when she starts her presentation. And she will share her expertise on the psychological aspects that affect intimacy in aging adults. Dr. Tangi is a clinical sexologist, sexual health educator, and surrogate partner therapy facilitator. She's also the founder and principal of Texas Sexual Health in North Texas. She is board certified by the American College of Sexologists, is a member of the World Association on Sexual Health, and an ambassador of the American Sex Health Association. She has been a media commentator and a contributor for several print and online publications, and her works about sexual health have been translated and published all over the world. Dr. Tangi is an advocate for sexual rights, including the right to sexual satisfaction throughout the lifespan. I want to thank each of our panelists for joining us today. And with that, I will ask Pam to guide you as we continue. Thank you, Pam.
Thank you. Again, good morning, everyone. We're going to go ahead and get started. And we will start today's webinar with EMILIJA, who will be speaking on the physical aspects of older adults in intimacy. So EMILIJA, take it away.
Thank you, Pam. I appreciate it. Again, I'm very happy you for inviting me. So I've been tasked with so for me, it's making sexual intercourse, and contrary to popular belief, there is a general in frequency of sexual activity. in both sexes after 65, but not as much as people think. 50% of older adults continue to be sexually active. That's defined as at least 1 month. So we have this notion in society that sex stops at a certain age, and it does not, and it doesn't have to. So I wanted to briefly touch upon that I deal with every day in my practice. So I come from the infectious disease background, and there are certain things that I see daily that don't really age is not something that prevents somebody from getting. I'm kind of alluding to the fact that STD rates among members older than 60 years have increased by 23% compared to 11% increase as STDs are rising, period, in every age group. But in older, they're seeing a 23% increase, so an even greater increase than normal. So that again goes back to the fact that people are having sex, and a lot of times people aren't aware of some of the things that can happen if safer sex isn't practiced. So in 2018, 17% of new HIV infections occurred in individuals 50 years and older. That's a factoid from the CDC, and that number is probably outdated by now. But anecdotally, I'd say that's representative of my patients. Say I see a healthy amount of people who are on the younger end of the spectrum and on 50 years and older. So why is there an increase? That's an interesting question because it has to do with multiple factors. So people are living longer. So we're living our best lives longer. There's an increase in midlife divorce. So Bill and Melinda Gates were a great example. They've been together for 20 plus years. And, you know, people separate, they go their separate ways and find new partners. At one point, there was a lack of sexual education. So older adults may not have gotten the push that came in the 80s and 90s regarding sex ed, especially during the AIDS epidemic. There was a big push regarding condom usage and all of that was drilled into people's heads, basically. So that may not have been brought across to everyone. And of course, the advent of Viagra. Viagra has revolutionized sexual health, and it has opened up many doors, and it has definitely caused an uptick in infections. So what are STDs, STIs? They're gonorrhea, chlamydia, herpes, syphilis, HIV, trichomonas, HPV. Some have colloquial names like the clap. That would be gonorrhea. Fun fact, the reason why it was named the clap is because one of the treatments was to clap out the offending discharge, which we have antibiotics for that now. So we don't do that anymore. So the reason why it's important to address these things before we even talk about sex as being an option is because this is real, this is out there, and clinicians, I place the blame a lot on clinicians for not going there, for not going into a robust sexual history with their older patients, for not asking the questions, for not leaving the door open, because a lot of times that can change the diagnosis. So for example, HIV and syphilis are usually not found until they're at their later stages. And a lot of times when syphilis gets to the later stage, it can be mistaken for dementia. So it is so important for clinicians, for providers to leave that door open, so that we can provide the best quality of care, because it's a part of being a human. So I always advocate condoms, condoms, condoms. Even if you can't get pregnant, condoms are the only way to prevent against STIs. The caveat being syphilis, you can get syphilis with intimate touching, and other sexual acts that don't involve penetration. So that is my little disclaimer before I go into the hot topics that people were very interested about. I perused the questions, and there seemed to be a great interest in erectile dysfunction or male sexual dysfunction and female sexual dysfunction. So my main focus is going to be on those two things, and how they relate to sexual intimacy. So one of the points was, what can I do about erectile dysfunction? Now, erectile dysfunction falls under a large umbrella. So that umbrella is male sexual dysfunction, and there's 3 pillars to it. So one of them being erectile dysfunction, another one being decreased libido, and the third one being ejaculatory disorders. So why I keep going back to it's important to have a provider who you can connect with is it really helps the provider figure out which treatment may be the most appropriate for you, because these 3 pillars get treated differently in medicine. So the first one, erectile dysfunction, it's defined as consistent or recurrent inability to acquire or sustain an erection of sufficient rigidity and duration for sexual intercourse. And so what can influence that? So a lot of times, various causes include diabetes. So diabetes is a big one. If you are a diabetic, diabetes basically attacks the vascular system. So you're gonna get diminished blood flow. So even, if you are a controlled diabetic, you may still have erectile dysfunction due to the systemic nature of the disease. Another factor would be hypertension or high blood pressure. So high blood pressure, again, affects the vascular system. So blood flow is one of those things that gets compromised. On the flip side, some of the things that can cause erectile dysfunction are the very same things we use to treat the diseases. So for example, sometimes high blood pressure medication can cause a side effect of erectile dysfunction. So the reason why I bring that up is because as we age, we are more likely to have high blood pressure or diabetes, and we're more likely to be placed on medication for that. Now, that doesn't mean that, I'm on blood pressure medication, that's it, there's nothing to do about it. There are so many blood pressure medications, and some can cause more side effects in people than others. So, which is why it's important to talk to your provider and communicate, hey, I'm experiencing these symptoms. Could there be something that you can do to help me? I personally have taken some of my male patients off of a certain blood pressure medication and put them on a less offending one, and that helped the erectile dysfunction. So, it's things like that that lay people may not know, but we do, and we can actually help. So cardiovascular disease, again, another thing that affects the vasculature. Anything having to do with decreasing blood flow will impact blood flow to the penis, basically. Thyroid disorders, that can have mixed effects. It can affect erectile dysfunction, but it can also cause depression. So the body is very, very interlinked. So one thing may have a cascading effect into other systems. But again, there is medication. And as we age, our thyroid, especially in women, when they reach menopause, our thyroid can start, some people call it burning out, but it can start not working as well as it used to. So it's really important to check in with a provider and say, hey, I'm feeling fatigued. My libido is low. Is there anything that could be causing this? Any organic cause to the symptoms I'm feeling? Smoking is a big one too. I don't know how prevalent it is in the general population, but I feel like a lot of my patients smoke, and it's one of those things that I always remind them, hey, it's gonna affect your vasculature again. So that means that the penis is not gonna work as well because it's the blood flow issue again. Obesity, that can be a cause. Drugs is a big one. What do I mean by drugs? I mean by prescription medications. So a lot of times when we get older, what tends to happen is you get one chronic disease, and then you get another chronic disease. You get one drug, 2 drugs, 3 drugs, 4 drugs. And you end up with, a whole bunch of drugs that you have to take every day to manage your conditions. Polypharmacy and all of that tends to occur. And a lot of times the drugs that we prescribe have side effects of loss of libido, erectile dysfunction. Some of the most common ones, we already talked about the high blood pressure medications, but antidepressants. I think, antidepressants are fantastic. They've really revolutionized mental health care. They're very important. But just like with high blood pressure medications, some of them can cause more side effects than others. So if you happen to be on an antidepressant and you're experiencing a loss of libido or sexual dysfunction, talk to your provider. There are alternatives that they can try, like buspirone or bupropion, that may be more appropriate for you. So there's a lot of things that medicine can do to help, maybe not restore the sexual function to the way it used to be, but at least, to get you to the point where the desire and the physical aspect are more in tune with each other. And the second pillar was the decreased libido. In men, especially, it tends to be about 5 to 15% of men who experience this. One of the main causes being testosterone deficiency. So as we age, the hormones tend to drop off. So in men especially, testosterone deficiency may manifest itself as fatigue, loss of libido, and all of that. And again, that's an easy test to do. We can screen for it. And it's something that can be ameliorated. Stress is a big one. So when you're stressed, you don't really want to have sex usually. Alcoholism is something that gets overlooked a lot. With the increased stress, I've been finding, especially with the pandemic, some of my patients, how do you cope with the increased amount of stress? You tend to drink a little bit more. So alcohol tends to have a suppressive effect when it comes to libido. Fatigue, recreational drugs, some other hormonal imbalances like hyperprolactinemia, low estradiol and thyroid disease. So all of those are hormonal imbalances that are easily diagnosed with a lab test. It's just the fact that leaving that door open, having good communication is the key to being able to kind of suss through all these issues. The final one is called the ejaculatory disorders. So things in that category include premature ejaculation, delayed and retrograde ejaculation, and anorgasmia. A lot of times these are caused by structural things. So with age, the prostate gets a little bit bigger. And when the prostate gets bigger, it can cause ejaculatory disorders. So in men especially. So that would be something that would be worth investigating, because there are so many things we can do for that. We can put the person on a drug that will help shrink the prostate. There's a procedure to a TERP to kind of shave down the prostate. So there are things that we can do to reverse some of the damage and some of the things that may present barriers to sexual intercourse. And I wanted to do a little quick note about psychiatric illness. Antipsychotics are also known to cause sexual dysfunction. So a lot of times loss of libido is a frequent symptom, particularly in people suffering from mood and anxiety disorders. So it's one of those things that is definitely worth reevaluating from time to time. I mean, I've had some patients who've been on a drug for 15 years, and they tell me, oh, I just don't feel like doing anything. My partner thinks I'm just a wet blanket. I don't know what's going on. And it's important to periodically reevaluate, okay, well, why have you been on this for 15 years? Or is there something better? Is there something that has come out within those 15 years that we can put you on that may decrease the side effects that you're feeling? So it's that communication aspect with your provider that can really open up doors and really improve the quality of life, basically. So for females, it's a little bit different. I found something quite interesting, that one of the main impediments for men was the physical aspect of their bodies. So, prostate issues or systemic illness, or things like that tended to be the main influencer of a less robust sexual life. But for women, it tended to, the most important thing was quality of relationship. So that it was striking to me, because women, older adults, older women, they still want to have sexual intercourse. It's just that the quality of the relationship was the main deciding factor, notwithstanding menopause and things like that. But menopause does tend to create kind of a point where the physical changes may influence women who there's a lot of body changes that happen, vaginal atrophy, lack of desire. I know there was one question in particular that asked me, well, what can I do if there's a lack of desire? I always say that there are things that you can do for that. There's vaginal gels, vaginal lubrication, moisturizers. There's also, hormone therapy. This has to be decided as a case-by-case basis. I wouldn't recommend estrogen for somebody who smokes or who has a history of blood clots. So it really is individual decision between the provider and the patient. But menopause does not have to be a limiting factor. So there are available therapies out there, especially for women who want to feel better about themselves and who want to live their lives to their fullest. So what I tend to see is I have a few patients on estrogen, and they've moved on past the menopause stage, and they're still, I got to keep my estrogen because it makes them feel good. It makes them not have to suffer through the menopausal symptoms that, like the night sweats, the uncomfortableness, the pain within intercourse, and there are options on testosterone, but there are options for women who want to pursue testosterone therapy. Now, it's a case-by-case basis with a provider, but testosterone therapy in women has been shown to increase libido, but it is only used when basically the lifestyle changes have not produced the results. What do I mean by lifestyle changes? Like counseling, psychotherapy, open communication with the partner, vaginal moisturizer, estrogen, things like that. If that all has failed and it's not producing the desired effects, then testosterone therapy for women is a possibility. Again, got to talk to your provider and make sure that that's appropriate for you.
Excuse me, Emilia?
Yes.
Hey, this is Pam. Okay, yes, we're not viewing you right now, but I just wanted to let you know you have about a minute left, and so that we can get ready to transition over to Dr. Tangi and open it up. Yeah, and open it up for the questions to hear from our participants. And we've got some questions we want to bring specifically to you here in a few minutes. Okay.
Great. Okay. I'm sorry. I could talk about this all day. I apologize.
There's no problem. It's interesting information.
Going and going. Cut me off. Okay. So one last thing I wanted to talk about, and then I will gladly hand over the spotlight. There was a few questions about vaginal prolapse and sex after hip surgery. So with the caveat of I'm not an orthopedic specialist or a urologist, but sex after surgery and with vaginal prolapse is completely possible, okay, and it just depends on the comfort level of the patient. So,
okay.
I do have 2 slides to show with the sexual positions. That is after hip surgery. I want to get for that.
Hey, Emilia, okay, for the sake of time, let's hold this one, if you don't mind, and bring this one back in when we bring that question up so that you can elaborate a little bit more about the hip surgery and utilizing some different positions.
Sure, of course.
Will that be okay with you?
That's perfectly
fine.
Okay,
great. Thank you.
You're welcome.
You. All right. Wow. Boy, you really gave us quite a bit of information there. So I'm sure.
It was a little overload.
Yeah, that's okay. Okay, well, we're going to go ahead and switch over to Dr. Tangi. When sex is not an option, and just addressing older adults and intimacy. Okay, Dr. Tangi, it's all yours.
Thank you so much, Ms. Pam, and thank you for our hosts for the invitation. And I am very glad to share this space today with Emilia for the first time. I think we complement each other a lot. As I was introduced earlier, I'm Dr. Tanginika-SIMONE. The name is phonetical, so it's just Tanginika-SIMONE, but they call me Dr. Tangi for easiness. I am a clinical sexologist in the DFW area. I'm an expert in sexual health, And my main clientele is actually individuals 50 and older. So this is a topic that is very dear to my heart, but also a topic not only that I deal with professionally, but as I age, I have these considerations towards the potential challenges on my sexual health that I am taking very close notes to, and also considering for myself. So thank you so much for having these conversations. They're so necessary. And as I see the angst and the suffering in the older population regarding sexual health, I feel like these opportunities are definitely very worthwhile and necessary to keep these conversations going. I am so glad about what Emilia said. We need to be more vigilant about the physiological causes of sexual health issues. And as practitioners that are not necessarily dealing with the physiological ramifications of these conditions, we need to be very aware. I know that we have some people in the audience who are getting their CEUs. So it is very important that when we see people for the first time, when we do that first intake, that first questionnaire, that we ask very thoroughly, and I do that in my practice, we ask very thoroughly about what are your health conditions, what are your medications, what are you on, what are your aches and pains, what are the supplements that you take, everything that I need to know. So in my practice, I devote 2 hours to that. My conversations are extremely thorough, and I sit down with them to understand what their bodies are doing at a certain point in time, and also what are their thoughts about sex, how they were raised, what is the quality of their relationships, because then I can construct this whole piece of information that is going to help bring the best outcomes for that client or patient. So it is very important that we do not deny that, or we do not omit that, and that we also bring into the conversation all the physiological ramifications of sexual health. So as has been said, I would like to focus on the emotional and psychological effects to the changes that adults face when their bodies or their partners face health challenges and changes in body ability. The first thing that I would like to say, and I would like to keep my remarks brief so I give more time for people in the Q&A, because I understand that people are very interested in knowing, how is this going to impact me? How can I deal with what is happening to me right now? And so that is very important to me. So I want to start the conversation by telling you that my objectives today is that you feel more empowered with information that will allow you to open up conversations about sex, whether you are a practitioner or whether you are a person in a relationship or a caregiver. So open up the conversations regarding sex and intimacy. This is not a taboo. I can say the word sex. The world didn't stop turning. Nobody died. It is okay. So we can do this. We can have these frank, open, and honest conversations. I would like for us to acquire some strategies to deal with the complexities and challenging of changing sex lives. Our bodies change, our needs and wants change, and therefore our sex lives change, but that doesn't mean that it is less than or worse. It just means that it's different. And also, I would like for us to adopt a more compassionate and empathetic point of view regarding what sex is and the importance of sex in everyone's lives. I always say that sex has no expiration date. There's no such thing as, oh, you are 60 years old, you shouldn't be thinking about sex. Or, oh, you reached your 80s, 80-year-old man shouldn't be wanting to have sex with another person. Or you're a 70-year-old widow, you're not supposed to be having sex or looking for a sex partner. That is not true. We all have the right to be sexual and enjoy intimacy until our very last breath, if we choose to do so. That is something that I would like to drill in everybody's head and change the mindset about not only our sexual rights, but also what sex is. And so I will take advantage of this opportunity to define, I know Kathleen did that very eloquently in the beginning, define sex. When we think about sex, think about intercourse, an erect penis into a moist vagina. And that's it. That's all we think about when we hear the word sex. Sex is so much more than that. And intimacy and sex can be related, can be intertwined, but they're not necessarily the same thing. They don't have to be together. Therefore, I am going to share with you different things. So prepare your ears, different things that you can do when sex is not an option, when intercourse, a penis and a vagina are not an option. Also, I would like to say that when we think about sex, if we only circumscribe ourselves to sex is only a penis and a vagina, we're excluding not only a whole another level of sexual activity, but we're also excluding people who can't have that for various reasons, or people whose preference doesn't lead to that. So like same-sex relationships, relationships in transgender and transsexual individuals that not necessarily have a penis or a vagina. So we need to expand our repertoire, and we need to really expand our definitions of what sex is, of what sexual activity is, of what healthy sexuality is, and what intimacy is. So if I haven't opened up your ears yet, here are some things that you may enjoy. So get ready for that. There are many conditions that may lead to a decrease in sexual activity. As Emilia said, obviously health conditions, that's a big one. And we are probably going to be faced with health challenges as we age that we have to be prepared for. And we need to also consider the impact of those health conditions, of medications for those health conditions, of surgeries, and our ability to have the sex that we used to have before. Because I have found that that's a great deal of the dissonance that people have later in life. Just because I cannot have the kind of sex that I used to be able to have, then I am inadequate, I am a failure, then I am not good enough, then sex is not an option, I can't have sex. Well, again, there's a lot of different things that come into this equation that I will elaborate on. Just because you cannot have the type of sex that you were able to have in your 20s and 30s doesn't make it less than, and it doesn't have to be less enjoyable than the kind of sex that you had before. Just because there's a limp penis doesn't mean that sex cannot happen. Just because the vagina is dry doesn't mean that sex cannot happen. So I just want to be very, very clear about that. There's changes in body ability. It's an imperative. You probably will not be able to have the kind of sex with the flexibility and the acrobatics that you were able to have before. Well, that's okay. It doesn't have to be marathon sex. It doesn't have to be sex for 3 hours. I see a lot of men in my practice, and they all lament about that. Well, I used to be able to go for 2 hours. I used to be able to ejaculate and then start again 5 minutes later. I used to be able to have sex 3 times a day. And now I'm able to have sex maybe every other day. Well, that's okay. We have to let go of that fear of missing out. It can transform into something else that is equally as enjoyable. Something that hinders us is the belief that once a certain age is reached, sex is off the table. So as I said before, I would like for everyone to challenge that paradigm and to deal with their own bias and to let go of that. There's no shelf life for sex. And our narrow definitions of what sex and intimacy are also some of the factors that hinder intimacy and sex in later years. So I would like, I am so sorry, a phone call came through and just muted my microphone. So there's sexual activities of all kinds, and intimacy is a sense of connection, enjoyment, bonding, a sense of belonging, trust, to be able to be vulnerable with one another, to be able to be open and enjoy each other's company. And that's a very broad definition, and it brings about a lot of opportunities to have a lot of fun in relationships, even when you are having health and body challenges. Before I get there, some of the psychological effects of these changes, I am going to talk from two perspectives. Number one, from the ones that are feeling or experiencing these changes. Maybe you are in a relationship and there's one who is having some trouble and the other one is feeling fine, and so that puts you in a differential in the dynamic. And also those who still want sex and they're feeling fine and they do not understand what the other person is feeling. So the ones that are not feeling sexual for some reason, they can deal with guilt for not wanting the sex, for not being able to please their partners. Fear of abandonment if they do not provide sex, that's a huge one, especially in women. Feeling of betrayal if the other person wants sexual pleasure in spite of the sufferer's refusal. I see that a lot. I see partners that say, well, because I can't, because I won't, because I am in this stage in my life, sex shouldn't be an option. He shouldn't want sex, shouldn't want sex. And that's not true. Feeling of betrayal if the other person pursues sexual pleasure in venues outside of their relationship, even if it means masturbation and watching porn, for instance, the other person just feels crushed, and insecurity. On those who still want sex, the feelings can be guilt from wanting sex in spite of knowing that their partners are dealing with health conditions that are not allowing them to be able to partake in sex as they used to. Frustration because they cannot have their needs met. Emptiness and abandonment feelings as they are not able to connect sexually with the other person. And guilt if they pursue sexual pleasure in other venues outside of the relationship. So as you can see, everybody is actually suffering from this. One of the main denominators here in the relationships are the lack of communication. That's going to be pivotal. That's going to be absolutely essential for you to come to agreements as to what is it that you are willing to do, what is it that you want to do, and what is it that the other person is able to accommodate as far as sexual connection within the relationship. And we each have that personal responsibility. And I would invite all of you to not shut that down. Just because I'm the sufferer doesn't mean that my responsibility is off the table now. I have the responsibility to communicate and to be empathetic. And I have the responsibility to understand and honor also what the other person is feeling and vice versa. So some of the activities that are still in the menu, if anybody is suffering from health conditions and body changes that are now allowing them to enjoy sex in the same way that they used to enjoy it 10, 20, 30 years ago. Saying I love you often, that is very basic and it goes a long way. Praise and validation. You look so pretty today. Thank you for cooking that meal for me. Oh, this is absolutely fantastic. You look lovely. That's a new haircut, whatever it is. Those words go also a long way. Kindness, you can never go wrong with it. More specifically, kissing, you can still kiss and it is very okay. Hugging, holding hands when you are in the house, when you're watching TV, locking legs when you are together. Masturbation, you can still masturbate on your own. Just because you're married, just because you're suffering from health conditions, just because the other person doesn't want to have intimacy doesn't mean that your body is off limits to you. And you should be pleasuring yourself and enjoying your own body also, so you can direct another person on how to pleasure you, on how to please you. You need to know that for yourself, and you need to have that appreciation for your own body. Mutual masturbation is always on the menu, can be a lot of fun. So petting each other, touching each other in every which way, in whatever way feels comfortable for the other person and you consent to. Masturbating in front of the other person with consent, One partner can do that while the other partner watches. You can take turns, or you can do it both at the same time. If you don't feel comfortable because there's some aches and pains in your bodies, you can still be in close proximity with each other and masturbate in front of each other, and that's quite a show. Sexy talk, sexting, just being erotic with each other, that's always good. Oral sex is always on the menu. So some dry vaginas still enjoy it, and limp penises still enjoy oral sex. If you have sensation, you can enjoy oral sex. Using erotica to increase arousal, cuddling, caressing, holding hands, as I said before, bathing together, massaging, doing enjoyable things together, trying different sexual positions, using pillows and wedges for support in sexual activity, changing the scenery, and the last one, humor. Laugh it off. I mean, our bodies are changing. The boobs are lower. Vulvas are drooping. Penises are going limp. We are more wrinkled. It's okay. Just laugh it off and just be frank, open, and honest, and enjoy each other. Humor goes a long way. You don't have to take yourselves so seriously. Just enjoy the ride. Some final recommendations: deal with your own bias, change your paradigm, get educated, and most importantly, talk about it. That's it. Back to Miss Pam.
Wow, that was exciting. I am particularly interested in that comment. Sex has no expiration date. And some points that you made relative to, lightening the load. We have become, we're pretty prudish as it relates to sex, intimacy, and the aging process. So what we're going to do now, if Emilia would turn your mic on, I'm going to go ahead and bring forth a few questions that have already come in. And if there are any participants who have questions, please go ahead and put them in the Q&A section. The Q&A section. We have already set up the chat to show names anonymously because some individuals may not want to be identified, which is okay. This is educational and enlightening for all of us. All right. Dr. Tangi, a question came in, actually was a comment. And the writer said she thought this topic was interesting, in which it is. She said her aunt is single, but wishes she had a male companion. The niece is very concerned about what to expect. What can you share relative to the concern that the niece has regarding her aunt who's wanting to have a male companion?
I think the main concern for me and the main concern for the niece should be the safe and security of her aunt. So obviously, how are we going to facilitate an encounter or situations in which she can meet potential partners? And then also, what are the safeguards that her aunt is going to have so she is protected should anything happen? But other than that, I would say also don't treat your aunt as a child. She has self-agency. She has the right to sexual pleasure and the right to have a male companion to share with in whatever which way she pleases. So I would say just be supportive. Just bring your concerns with a lot of respect and offer to be there to provide her safeguards for her safety. And other than that, create that framework around her so she feels safe and supported, and let her be.
Okay, great. Emilia, you really provided quite a bit of information regarding erectile, dysfunction. Is there a specific doctor, a specialist that a person should go to should he be experiencing erectile dysfunction?
That's a good question. I am remiss for not spending a little more time on the women's sexual dysfunction. Perhaps I will do a little better job at that next time. But your primary care provider can help you.
Okay.
You don't require a specialist. There's really primary care can do a whole lot of things. And if you just say, hey, I have these issues, what can you do for me? That's a good start.
Okay, okay.
Ms. Pam, I would like to add something to that.
Go ahead.
There's, always obviously talk about it, but if you feel like you haven't gotten the answers, just continue to search. There's obviously the urologist, there's the sexual medicine doctors who deal with the most intricate aspects of sexual function. In my own clinic, I am in Texas Sexual Health, but also now part of Renewal Medical Centers, and we do some physical medicine that impacts sexual health and to bring about sexual functioning and restore sexual function in a more holistic way, with changing the pelvic floor musculature, bringing about more blood flow and those kinds of things. It's not an advertisement, but pills are not the only option and injections are not the only options. There are more options in the marketplace. There's new technology that also brings about regeneration. So there's a lot of different options. You just have to get educated. And unfortunately, it's a little bit hard to navigate that landscape, but there are multiple practitioners out there that would be able to help and at least present you with a fan of options that you can be comfortable with choosing from.
Okay, great, great. Well, that's really helpful. Hey, Amelia, here's a question that came in that we're going to bring to you. If both partners have been vaccinated but received the COVID-19 vaccine, is sex okay?
I see no problem with it.
Okay.
Maskless even.
Maskless, okay, okay, okay. Now, Amelia, what if one has been vaccinated and the other hasn't been? What's kind of recommended there?
Well, the CDC recommends that that not be. The CDC is very interesting. The likelihood of passing COVID in that scenario is low. But if that person is at high risk for any kind of complication from COVID, if they have comorbid factors, uncontrolled diabetes, things like that, then, I would caution, hey, get vaccinated and go on with your life like that. But the CDC, as it stands, does not recommend vaccinated and unvaccinated people commingle. But that never stopped anyone during the pandemic, and my STD rates were sky high during the pandemic.
Okay. Kathleen, Shannon, did any additional questions come in through the Q&A that either one want to bring forth?
Yes, so we do have a few. One of them is, how can I increase my stamina and energy level during sex? I still have a good libido, but I tire more easily. I'm in my late 60s and I am on Synthroid for low thyroid. What kind of lubricants do you recommend for dryness in women? I can't go on hormone replacement therapy as breast cancer runs high in my family.
Okay.
Well, okay, behaviorally, obviously I wouldn't have necessarily anything to say as far as the medication, but behaviorally, I'm going back to what I said before. Do not expect yourself to have the kind of sex that you had before. We have to let go of that idea. I am not going to sugarcoat it for you. Just because you were able to have this kind of sex, a year ago, 2 years ago, yes, it is sad, it is devastating, yes, it is disappointing, but just change it to something else that will be quite as enjoyable. Sensations haven't changed. Just because you cannot overextend yourself and probably, again, be more vigorous during sex doesn't mean that the sensations have decreased, have diminished, and that you cannot have those erotic sensations and potent orgasms and ejaculation and all that unless you're impaired that way. But again, just adapt to what you can do now. Change positions, change or aid in certain ways, as I said, with pillows and wedges. They are readily available in sex shops or Amazon. Everything is in Amazon these days. And you can find different things to like prop your body, maybe prop your partner's body, and just adapt to the level of activity that you can sustain. As far as lubrication, I always recommend lubrication for everybody, regardless of whether or not you're having hormonal changes or not. There's also other therapies. There are hyaluronic acid suppositories for women that they can put inside, that they can plump back that tissue. There's CO2 therapy that they can also put in their vaginas that will restore some of that plumpness and that moisture in the vagina. But always go for the lubrication. Don't expect yourself to have all of a sudden a moist vagina. And if you don't, feel bad about it. Well, go buy a jar and have it by your nightstand and use it. And that's it. So again, don't reminisce and just feel bad for what you used to have or be. Adapt to what you're now.
I'd like to add a quick point to that. I completely agree with the expectations and putting that in, framing that in the context of the here and now. I also want to add, I always recommend water-based lubrication.
Yes, absolutely.
That tends to be a little more gentle and it doesn't cause as much irritation.
Yes.
But if you have not had your thyroid levels checked, perhaps the Synthroid may need to be changed, but that is completely a decision that needs to be made on a case-by-case basis.
Okay.
Thank you. Pam, our next question is actually one that I think that you can help address as well. How can we encourage intimacy when family members think differently about it for their cared ones? And I think this is kind of referring to relationships in the nursing home, assisted living setting, in addition to in the home setting.
Wow. That's a very tough question. And it is an issue that comes up, and we're starting to see it arise more. And we're going to go back to the definition of intimacy that you spoke about, Kathleen, and Dr. Tangi, spoke about. Even though a person is in a long-term care community, that does not negate the fact that, and the reality that there's still a desire, a need for intimacy, for that closeness. And there's also could be, the desire for sexuality. In the care communities, family members have a right to be engaged in the care planning process, but each long-term care community across this country, nursing homes and assisted living facilities, will always advocate for the residents' rights, okay? The resident has the right to choose, and though someone is in a care community, that does not take away that person's right to express himself or herself, express their intimacy and their sexuality in a very appropriate and safe manner. If the family is concerned about that person's cognitive ability to make that kind of an informed decision, they can always have that person evaluated by psych services, we find that administrators may become very nervous relative to a person's capacity, but they have the responsibility to advocate for that person's rights and to do it with the family in a way in which they are being educated, as well. Okay, thank you. Let me ask one to both Emilia and Dr. T, and it may even come back to the long-term care area, and it has to do with ethics around sex and dementia. Dr. T, let's start with you. How would you respond?
I always say that for the person who has probably a higher level of cognitive functioning, it is very important that they make sure that the other person is able to bring about or express consent, that they are informed about what's going to happen, and that there's some level of understanding. The person who has a greater cognitive ability cannot just take advantage of somebody who is compromised in that ability. If it's happening in a assisted living setting or long-term care facility, Ms. Pam, I would like for you to intervene or interject because you have a wealth of knowledge there. As far as I'm concerned, how do you gauge that? That's very tricky. If it's a relationship that has been going on for a long time, I am sure that you can gauge and you can know when that person has maybe a moment of lucidity, maybe when that person is more awake and alert, maybe when that person is more able to express what is it that they're feeling or wanting or needing at that moment, and refrain from taking advantage of the situations when that person is not able to. For instance, I know people with narcolepsy, and so they have windows of opportunity in which they're lucid and they're talking and they're up and they're aware, and then there's other times in which it is clear that their cognitive ability is declining. They need to just lay down, sleep it off, whatever it is that they need to do. Well, you're not going to go and initiate sexual activity during that time. You are going to wait until that person is able to be present and to ethically and tell you, hey, I am up for this. So you just have to be able to navigate that fine line. Again, when there's people who don't necessarily know each other that well, like in a long-term care facility, I would let Ms. Pam speak to that.
Okay. And let me go to Emilia before I come in. Is there anything that you would like to add, Emilia?
That's a difficult kind of question, and it's not, there's really not like a one answer for it, because everyone is a little different, because dementia can be mild, dementia can be moderate or severe. It's a spectrum. So I can't really give a boilerplate answer to that. Somebody with mild dementia may have all their faculties and be able to consent and be their own advocate. But somebody with more severe dementia may need to have an advocate be there for them. So that's kind of a slippery concept, I would say, and especially in group living situations where there's not an equilibrium and people are in different areas when it comes to that. So it really is a case by case thing, and advocating for yourself is the number one thing.
Okay. All right. Okay. Well, I'm going to try to be as succinct as possible because clock is ticking away on us. What is very important that's already been mentioned by our two fantastic speakers, and that is consent. Even though a person has a diagnosis of dementia, and in most long-term care communities, most of the residents will have a diagnosis of dementia. And simply having that diagnosis does not mean the person lacks the mental capacity to make their own decisions. And that capacity is always specific to a particular decision at a particular time. As both speakers have already indicated the continuum, and that there could be a medical contributor to some decision-making capacity. Emilia certainly spoke at length about medications. Medications can certainly have a bearing. So in essence, anyone with a diagnosis of dementia, or if there's any concern relative to a resident's capacity, to cognitive capacity, we want to keep in mind that no single person, and this is very hard to take for adult children, no single person should make the decision for another to have an intimate relationship. In the care communities, residents, the residents interdisciplinary assess the resident's level of capacity to determine the benefits and potential harm. So consent is very important, and we also monitor to ensure that residents are not being exploited by staff or anyone who would not have that person's best interest at heart. So it puts a big onus on the facility to monitor that. We encourage family members to keep that communication going. We have even talked with the facilities about having a sexual intimacy policy. There's one nursing home community in the United States that's embraced it. It's called the Hebrew House out of New York. And we will provide some additional resources, hopefully for you all at the end, or we'll send it to you at another time. So the clock has gotten away from us. This is always such an exciting topic. There's certainly so much more to talk about. We want to thank our speakers and for coming forth and bringing this topic, and for all of the attendees who came out this afternoon to be a part of this incredible conversation. So I'm going to pass this back over to Kathleen for the closing.
Thank you, Pam. Appreciate it. I want to take a moment to thank our participants for joining us today. And I also want to thank the Senior Source Caregiver Support Program, Prism Health of North Texas, Seniors Blue Book, and our panelists, Pam, Emilia, and Dr. Tangi, for their participation in creating such a great event today. I think that we probably could have a 3-hour program on this and it still would not be enough. So I think that Shannon and I will get together and try and plan a follow-up